Well, good evening and welcome back everyone to our Exam Pro webinars again for the 2022 AUBo oral board examinations. This evening, our session, which will again be recorded and archived for Tuesday, September 6th, 2022. I'm your host again, Robert Gaze. Thank you for joining us again this evening. Our apologies for Sunday evening for those of you who are with us. With about 15 minutes left in the webinar, we actually had a neighborhood area power outage where we originate here, and we're unable to recover the webinar. So we'd like to start where we left off. We were, I believe, speaking with Dr. Furcio at that point, and we were working on a case of PPROM, and I'd like to get right back to that and carry on from there and have as many of our candidates as possible participate this evening. So with that, let's get right to our case list, which are sitting right here. And Dr. Furcio, thank you for raising your hand. Let me get you unmuted here for a moment and pull your case list. Still not alphabetized, so we'll just kind of wander through until we find it. It's right here. Let's see, Melissa, can you hear us okay?
Yes. Can you hear me?
Oh, good. Hey, well, yes, welcome back. Thanks for joining us again. Yeah, we were looking at your OB case 11, as I recall, and we had actually just modified it so we could talk about sort of PPROM remote from term. It is right here, case 11. Here, I think we had made this PPROM at around 25 to 26 weeks or so, if I recall.
Yeah.
And I think we were talking about just sort of our initial evaluation here. If we could, let's maybe pick up there. So the examiner might ask, sometimes they'll just sort of come in from where you are in your practice. In your hospital, to what level of prematurity can your NICU manage acutely delivered preterm infants?
32 weeks and beyond.
30 weeks and beyond. Good. So if at 25 weeks we have a woman who comes in who reports leakage of fluid, and on your initial examination you do document there's preterm PPROM at 25 to 26 weeks. How would you proceed with your evaluation of this patient? You had alluded to some initial things. I think you were going to look at the monitor for contractions. You were looking for the fetal heart rate. What else would your initial evaluation consist of?
Looking at evaluation for contractions, category 1, 2, or 3 tracing. I had sort of visually assessed as far as if she, if cervix appeared dilated or not. Assessed her vital signs and asked her for any other like symptoms, if she had noted any pain, any vaginal bleeding, any recent trauma. Beyond that, if this was her otherwise first assessment, and now we've confirmed that she is in fact PPROM at 25 weeks. At my institution, essentially the goal is to determine is fetus stable at this point, is mother stable at this point, as far as for potential maternal transport. So I will usually also get an ultrasound, assess position of the baby, as well as the remaining AFI, and start her on latency antibiotics. Also start her on a course of betamethasone, as well as mag sulfate for neuroprotection. And then also collect a GBS swab for reference, and then if deemed stable, be able to transport her.
How far away is your resource hospital transport?
An hour.
An hour away. Good. This is a discussion that I hope we'd be able to have. The examiners would ask, so tell me please, how do you determine that this fetus is stable for transport and this mother is stable for transport? Can you give us examples of your specific criteria that you assess in determining whether it is safe to transfer right now?
So from the maternal standpoint, I'm looking at stable vital signs, assessment of any pain that she's in, and any vaginal bleeding that she's having. I guess essentially I want to be sure that she is not septic or abrupting in general terms. From a
I-
fetal
how
standpoint,
would you determine that? How would you assess for abruption?
um, I mean, assessing for abruption is I mean, more of a clinical diagnosis, if anything, as far as for presence of vaginal, like significant vaginal bleeding on exam. It's poorly assessed on ultrasound.
Mhm.
Um, but
If you suspected an abruption, would that influence your decision as to whether to transfer the patient now?
absolutely, I would not
Uh,
choose to
what
transport her.
clinical
I would
signs would make you then suspect abruption?
say, can you repeat that, please?
Sure. I'm sorry, what clinical signs then would lead you to suspect abruption?
Abdominal pain, vaginal bleeding, uterine contractions, fetal decelerations.
Sounds good. Nice. That was a very nice list. Now, are there any other things that would be important criteria for you to assess, which at present would absolutely not, you would absolutely not transfer the fetus and the mother?
Progression into active labor. So I'll
Mm,
frequently keep them for 2 or 3 hours, as well as keeping them on continuous toco to,
sure.
because I don't want her to deliver in an ambulance.
Mhm. Okay. And what will you be watching for during that time?
Well, I try to if I'm able to appropriately if I feel comfortable with my visual inspection as far as cervical dilation, as well as if I'm comfortable with that, then I'm keeping her on continuous toco and um if hoping for, less than I'm hoping for not regular contractions over the next couple of hours. Um, there are some cases where I don't typically give tocolytics in ruptured membrane setting, but I do give them from time to time for a maternal transport reason.
Oh, and what tocolytic would you use in that case?
At 25 weeks, I would tend to give a one-time dose of indomethacin.
Listen, good. Okay. Are there other tocolytics that you use in your practice when you have situations of a preterm labor?
Yes, other ones that I would use would include Procardia or
Mhm.
terbutaline sometimes.
Good. Um, if in an instance like this, there was a precipitous delivery at 25 weeks, how are you equipped to resuscitate and stabilize a 25-week fetus in your institution?
We do have the supplies, as
Mhm.
well as like we do have a pediatric hospitalist always in-house, as well as
Mhm.
appropriate supplies for that. We just usually call the tertiary care NICU, and they come by helicopter. So we have the stabilization in order for appropriate like mechanical ventilation and stabilization for short-term periods of time.
Mhm.
So we feel comfortable, if somebody has an imminent delivery at 24, 25, 26 weeks and need to make that call, being able to do so. Just my NICU does not feel comfortable keeping the
Yes.
baby for 12, 18, 24 plus hours.
Yes, but you said you had the facilities including mechanical ventilation. Is that something that you would be doing as the attending obstetrician?
No, no.
Okay. This is something that has come up in the exam. If this baby was delivered at 25 weeks and was delivered apneic, would you intubate the baby?
Would I personally
Yes.
intubate the baby?
Yes.
Um, at my institution, my nurse anesthetists feel comfortable doing intubations of preterm infants.
Good. If this were in the triage area and your nurse anesthetist were not on the unit, would you intubate the baby?
I would feel comfortable providing continuous bag mask ventilation, but I can't say that I would feel comfortable intubating a 25-week fetus.
That sounds great. Good. I'm simply in the exam. The examiners actually will push points like this, and they will push to be sure that you keep pushing back, because neither you nor I think, are really qualified to safely intubate a 25-week infant. That requires a level of expertise that's beyond anything we've been trained for, and we could certainly cause significant harm to a baby who is already fairly fragile doing that. So you're exactly right. No matter what they say, they might say the baby is apneic and the baby's heartbeat is now 30. Well, won't you intubate the baby right now? You allow that you do have people in your institution who can come running quickly from other parts of the hospital who would probably be able to help you, and that's the proper answer to give. And you can bag and mask and provide oxygen to the infant. But you're exactly right. This is not something that you or I would do. But that was perfect. You would pass that question in a moment, and they would probably move on to something else. If they push that a little bit and you continue to push back, that's exactly right.
Okay.
Listen, that was actually very, very nicely done. And for starting off, when I anticipated that we were talking on this evening, I had no idea where this case was going to go. I was just sort of following the discussion and your information about sort of how things are in your institution. And those are logical questions in a situation where we have a NICU that doesn't handle infants below a certain point, but which an infant certainly can be precipitously delivered that in, to ask about sort of what resources we have available, and also what we as the obstetrician would do. And there are certainly things that we can and should do, and there are certain things that, because it would be potentially harmful to babies, we wouldn't do. I could ask you briefly, because you did a really good job and you stood up the case very, very well. As I was sort of pushing you on that, and I apologize for making you uncomfortable, but that's sort of how the exam would be. Were you leaning toward at any point that you might feel that you would need to say, yes, I would intubate the baby?
I know that you were like pushing me towards that direction,
Yeah.
but I felt that that saying that I like, because I would literally have zero comfort in doing that.
Good. I'm
So
glad.
for something that I have literally zero comfort in, I felt that that was the right answer.
You will not do it if you have no resources available and nobody else in the room, but you and a nurse is available to the patient, and the infant unfortunately dies. We would not intubate in that situation. That's absolutely right. Agreed. That is something which causes a much greater risk of severe harm to the baby, which could cost the baby's life than doing any good. And I absolutely agree with you on that. Good. Thank you, Melissa. Thank you for doing that. That was a strong performance there. Thank you.
Thank
So
you.
we should allow you a moment. Would you like to discuss anything further about this case, or sort of any other questions or sort of angles on this that you'd like us to discuss for a minute or two?
I don't think so. I mean, I kind of had guessed on the hint that you were going to take the case into a direction of, well, what if this was at a different gestational age than the one that you presented with, which I know that that's a very fair, very fair topic with a lot of OB stuff. So.
And a common thing, particularly for this one, because again, most of us, if we have preterm delivery or PPROM, that usually is maybe 34 to 37 weeks or something like that. Some of us do actually have really preterm deliveries, but there are many, many cases in which all of the PPROM and the preterm labor stuff is fairly close to term, and it's much more, I think, valuable for them to make the infant much more preterm and then ask us, because there's a lot more assessment. There's the issue of then a prolonged latency, and how do we manage people for weeks in the hospital if they are prolonged PPROM. Lots of different angles that can get to that really don't make sense after about 34 to 35 weeks or so in general. Good, Melissa, thank you very much. Right, we will ratchet down the pressure level a little bit for our next few cases here. I think we'll just go down our list here. Thank you. We've actually got 1, 2, 3, 4, 5, 6, 7. Great, lots of candidates up. Dr. Walker, Alyssa, I'm going to come to you in just a moment, and as we're getting you unmuted, I just want to get back to our case list here. Just a second. Alyssa, can you hear us okay?
Yes, sir, I can. Can you pronounce your last name again for me?
Yeah, Pegues. Everybody calls me Dr. Bob. Feel free to do that. But it's pronounced Pegues. They're kind of, I think on CBS News, there's a Jeff Pegues. You can sort of pronounce it like that, and that's perfectly okay too. It's the same. Dr. Bob works great also. I think this is Dr. Walker. I think this is you right here. Let me just check. I believe it is. Okay. Let's see. So anything particular, Lucy, you would like to talk about GYN office or OB?
Well, you know, since we did the office, since we did OB, let's go to office.
Sounds good. Thanks. Are you looking at anything particular on your OB cases as you're just sort of getting settled into study for the exam as far as a topic that you were finding interesting or anything that you'd like us to ask about this particularly on your case list?
No, sir, nothing in particular. Just let's just go with your favorite number.
That's all fine. Okay. Let's see. Let's see. We did preconception counseling, I think, on Sunday, so maybe pick a little bit something else. Okay. Can we ask about case number 9? Very everybody. There's a rule in OB. Everybody gets asked about hypertensive disorders of pregnancy and GYN. Everybody gets asked about the ureter and hysterectomy, and office. Everybody gets asked about AUB. So this is a 20-year-old null-gravid patient. It simply says heavy menstrual periods and obesity. So there's a lot of sort of undefinition here. We don't know the degree of the obesity. We don't know much about the HMB. So that would be interesting. So I think they would ask you, in your practice, when a young patient under the age of 21 presents with reporting heavy menstrual periods, what sort of things might cause this to be a relatively recent occurrence in a 20-year-old woman?
Sure. So the first things that tend to come to mind could be that she could have some type of coagulopathy. Of course, they present a little bit younger than that, but you know,
that's good. Good.
And then also it could be obesity in her case for sure. This unopposed estrogen on the uterine endometrial lining. Also, you think about things such as PCOS that could cause this irregular heavy bleeding. And then sometimes it's just the fact that these girls have, they may be on the medications that, again, she's young, so she may not be on anything like that, but blood thinners can certainly cause heavy periods as well.
So at what level of obesity would you be concerned about unopposed estrogen stimulation on the endometrium in a 20-year-old?
Sure. So I would say typically we see this around a BMI of 30 or higher. We tend to see this heavy abnormal bleeding. You can see it in overweight patients with a BMI of 25, but typically in the obese patients due to this unopposed estrogen and ovulatory bleeding.
So since I'd say more often than not, a patient who comes into our practice is probably going to have a BMI of 30 or more. It sounds like most of the patients in your practice who present like this might have unopposed estrogen stimulation as a potential diagnosis.
Correct. Yes, sir.
Okay. So if that is your thought, how might you evaluate further if that were high in your differential diagnosis list? What would be the characteristics of otherwise of a woman who presented with heavy menstrual periods and it's actually due to underlying unopposed estrogen stimulation?
Well, I always kind of first start off with getting a very good history. A lot of times the history can tell you the majority of what's going on. I often have them do a menstrual diary to kind of pinpoint how long the bleeding is, how many pads they're going through, even to the point of becoming symptomatic. Some patients become symptomatic with the bleeding. And so a lot of times, really, I just base the diagnosis off of the history taking, which tends to kind of gives me what I need from that point. As far as working the patient up, I think it's very important to do an ultrasound just to make sure you can kind of look at the lining. Although it's important to note that in these premenopausal girls, the thickened lining doesn't really mean much. But you
good. No, I'm glad you came to that. Good. Carry on.
Yes, sir. So, but it's always good to have just so that you can kind of see exactly what's going on as far as the uterus itself. And then, as I said, looking at the diary, the history, it kind of helps you to know. And then, of course, the BMI, a lot of times that gives you the picture. You can also do a workup for PCOS. Sometimes that goes hand in hand with the obesity. Not always, but it certainly can go hand in hand with obesity, PCOS.
So would you, in this patient, would you generally get an ultrasound to evaluate the endometrium?
I would, if she was having pain, if she, if I was concerned about fibroids, again, she's 20 years old, you don't need a lot of that, but, every patient is different. So you want to really kind of analyze the patient on an individual basis. But no, I would not put that in my number one workup. It would basically be the history and physical and the menstrual diary.
Okay, so going back to this, what would be the basic characteristics of a 20-year-old who had heavy menstrual periods that was actually due to underlying unopposed estrogen stimulation? Aside from you allow that she could be obese, what would be some other familiar characteristics of a woman in that situation?
I'm not sure I understand the question. Could you rephrase it? I apologize.
Sure. What sort of things would turn up in your history and physical exam in a woman who had heavy menstrual periods that was due to underlying unopposed estrogen stimulation?
Okay, what other things would be in the history? Well, she could certainly, she would mention how many pads she was going through. She would mention.
So her periods would be heavy. Are you saying that they'd be heavy?
They would be heavy. Yes, sir. Yeah. She would mention clots as well.
Anything else in history that would be really important to ask her?
Say that one more time.
Anything else in history that would be really important to ask her?
Anything in the history? You could also ask if she has, well, how long this has been going on. Is it just starting, or did it start from the very beginning? Does she have any bleeding disorders in her family? Or if she gets a nosebleed, does it bleed continually?
How would you define unopposed estrogen stimulation in a patient like this?
How would I define that?
I mean, we use the term abnormal uterine bleeding. There are a lot of different causes of it. How would you define unopposed estrogen stimulation when we're thinking about this as a diagnosis for this patient? Well, one very important thing that we haven't come to yet, although you sort of landed on it just briefly for a second when you mentioned something else there.
Right. Okay. So it sounds like I think I understand the path that you're kind of leading me down, but so in order to truly diagnose her as this unopposed, or I guess anovulatory bleeds, I should say anovulatory bleeds, you could give her a progesterone challenge test, and that would certainly help you to understand.
Does that make the diagnosis of unopposed estrogen stimulation if you give her a progesterone challenge and she bleeds?
It wouldn't necessarily make the diagnosis. It would help you understand.
What needs to be going on here in order for this 20-year-old woman to have heavy bleeding due to unopposed estrogen stimulation? Because it's something very basic. This is, I think, a great example of these things that are so obvious that we just have to sort of remember to say them, because I know that you're thinking this, but we just haven't verbalized it just yet.
The fact that she's obese?
No, okay, she's obese, but unopposed estrogen stimulation. That's when we were talking in our courses, we always say when you're looking at structured cases and scenarios that the examiners put up, just like for the written exam, I teach about keywords. The keyword is always a modifier. It's always an adjective, sort of what sort of estrogen stimulation? Unopposed estrogen stimulation. What's the menstrual pattern of a woman who has unopposed estrogen stimulation?
She would have the are you alluding to the breakthrough bleeding, or just heavy?
Would she have regular cyclic menses, or would she have another sort of menstrual pattern?
So for this particular patient, she was just having the heavy bleeding. It's nothing.
But we're talking about the hypothetical case now. You brought up unopposed estrogen stimulation. That was sort of toward the front. So what sort of pattern of menstrual periods would a woman with unopposed estrogen stimulation type bleeding usually have?
She would just have
regular cyclic menstrual periods, or would it be another sort of pattern?
So if she's having anovulatory bleeds, it would.
Right. What's anovulatory bleeding involved? There you go.
Okay, so anovulatory. I'm trying to pull back from the question. So
good job. Yeah. So how often would a woman in that situation be bleeding? Would it be every month?
So for these patients, they would not bleed every month. They would have
Right, yes.
very,
How frequently would they bleed? And you don't have to give me a number, just very frequently, somewhat frequently, or not
no,
frequently at all.
it wouldn't be frequently at all. They have like this
Right.
only
They would have oligomenorrhea. That's where the PCOS, I think, was coming in, right? In order to have unopposed estrogen stimulation, there has to be prolonged periods without a progesterone phase of a menstrual cycle, right? Because the average 20-year-old is having heavy menstrual periods and cycling every month. She never gets unopposed estrogen because she's balancing her estrogen with progesterone every 28 days or so. But that was the one thing that examiners will just sort of push until we get to it. This woman is going to be, it's going to be really obvious when you take your menstrual history, because she's only going to be having maybe 2 to 3 menstrual periods a year, maybe 4, something like that. Not very many, really. Anovulatory oligo menstrual bleeding pattern. Good. Would a endometrial thickness assessment help you in a case like this?
No, it would not. No,
No, good. So if you're concerned about unopposed estrogen stimulation as a cause of this woman's bleeding, what at the age of 20, are there any other things that you're concerned about? Could she perhaps have a endometrial hyperplasia or EIN?
That certainly could be a possibility with the fact that she's any person with unopposed estrogen, you would be concerned about that.
Good. We would expect that more in someone in her 30s, 40s who've been menstruating for decades. But you're right. In certain circumstances, depending on the degree of obesity and the higher levels of unopposed estrogen stimulation, we cannot exclude that. So so you sort of brought that up after coagulopathy. That was sort of up in your top of your differential diagnosis. So how could you then identify that perhaps that's what's going on with this woman?
So if I was thinking along the lines of coagulopathy, you would certainly
let's do coagulopathy. We're thinking about unopposed estrogen stimulation.
Oh, okay. Okay, so then you said your question is what again?
Is there a way you could diagnose it, or is it just a presumptive diagnosis?
Oh, for the unopposed estrogen?
Yeah, right.
Yes, again, it would just be something that's more so presumptive, something where the patient will ask, or she would kind of divulge this information to you.
Very infrequent menstrual periods, prolonged periods of estrogen without progesterone balance, and then sort of maybe heavy, irregular, uncontrolled bleeding patterns. It would be reasonable to suspect unopposed estrogen. Now, we talked about women who at the age of 20, could potentially have a endometrial hyperplasia or so. Is there a way to diagnose that?
Well, if you're thinking that, then you would have to do an endometrial biopsy at that point.
Perfect. That's perfect. That's all we needed to get to. Excellent. And then, so last question, if this woman actually then ends up having a simple endometrial hyperplasia and her menstrual periods are 3 times a year, what sort of management would you recommend to her that could maybe help to alleviate those problems?
Well, you'd have to kind of ask what she wants to do. If she was concerned about getting pregnant right away, or she just wanted the bleeding to kind of stop, the pain to stop, the cramping to stop, then you would certainly offer birth control at that point. Really have to assess.
I'm going to interrupt you for a moment because I know exactly what you're talking about. But no, this is just a start point. In the examination, birth control can be 16 different things, and that includes a diaphragm. But what you mean, I believe, is the term we should use is combination oral contraceptives. Is that where you want to go?
Yes, I was going to go to yes.
So I think the way to say it is we could use, I think maybe instead of birth control, when we're pressing for the exam, let's talk about hormonal contraceptive options. And then you say, and my choice might be a balanced combination oral contraceptive. That's what we do just want to, but this is just sort of as we practice for the exam. By the time we got there, we wanted to be more natural, that we just sort of couch things in that kind of language. So the examiners will pick up on it right away. Because birth control is a little bit vague. Good, and I'm with you completely. Good, and they could ask you. There's lots of more questions they could go on about, sort of what dosage or formulation of oral contraceptive would you use? How would you structure it? Do we do it cyclically or continuously? Lots of other stuff. But you've actually gone through a lot on this case, and we've gotten a lot done. So I think we should thank you and let you step down for this one. But let's, for a moment, is there anything you'd like to ask about this? Again, these cases tonight are just sort of developing as they are. I wasn't really thinking unopposed estrogen stimulation in a 20-year-old, but it came up very early on, and the examiners will just follow it. So we have to be prepared when stuff comes out of our mouth, just to be able to practice and follow it through. And one of the values of doing just sort of short courses of oral exam practice with different people, just people you have at home, or people you're doing on the telephone with, is they will sort of allow you to lead it some way, and you'll sort of figure out how to discuss these things that just sort of end up being left turns that you take. Because I think in the average 20-year-old with obesity and heavy menstrual periods, it's unopposed estrogen stimulation is not likely. There's a maybe single unit percentage, maybe 3, 5, 7% of women actually would have PCOS or would have, unopposed estrogen stimulation, and most of them have something completely different related to cyclic menses. But we got into something that was kind of an unusual thing in a 20-year-old, and we just went there.
Sure.
And it's okay. And the key thing about that is just the things that we sort of really have to sort of just when the examiners keep sort of pushing us, I like you stepped back from it, and we had to sort of think about how do you define unopposed estrogen stimulation, and it really is just very frequent menstrual periods.
Right.
That's good.
Thank you.
Good. Thank you for stepping up and doing that. That's actually great. Let's go. Let's see, Dr. Castillo. I think Jamie, I'm going to try and get your case list up here for a moment while I'm trying to unmute you here. Just going to go back here. Oh, I think this is Jamie right here. Let's see. Dr. Castillo, I'm sorry, let me try that again. I think now if you unmute yourself, I think Jamie will have it.
Yes.
Oh, good. Hi, I got you there. Good, thank you. Thank you. So you get to choose, please, OB/GYN or office practice?
Let's go with GYN then.
All right. That's good. Are you looking at any particular topic or just anything on your case list that's really something you'd like to bring up this evening? You got some. I really like the way you've
Any
numbered
of my
things.
complications probably would be best.
Anything with complications. Okay. Although interestingly enough, it's surprising how little they gravitate stuff like
Okay.
let's see, lumbar limits. That's not much of a complication. Let's see what else we got here. You got so far a pretty uncomplicated case list here.
Until you look at the bottom.
Until you look at the bottom. All right, Paul. There we go. Now we're getting complications because that's where they live. Good. Let's see.
A very long one, I think.
That's
That's
right.
Let's
see. Yeah, unsterilized LEAP instruments, or I don't think they'll actually go there in the examination.
Okay.
Although I'm sure there's a story that goes along with that. Let's see. I think we could pick up. Let's pick maybe case number 43.
Okay.
Just something we can talk about kind of briefly, because there's a lot going on in this case. Let me just move it up here actually so all of our candidates can see case number 43. So there's a bunch of stuff. There's AUB with a bit of a sort of myomatous uterus in there. There's iron deficiency anemia. There's some failed medical management. She had an abdominal robotic converted to exploratory laparotomy. That would be something to prepare to discuss. Where I was thinking of going here, because just anemia and blood transfusion, it turns up really common in these cases, is in an operation like this, how do you determine when and when not you would administer blood products to a patient during an operation? What criteria can you come up with for me that would, in your mind, be indications to transfuse a patient during a surgical procedure, as opposed to afterwards, after assessing how she did and looking at her blood loss and assessing some post-op labs?
I think part of my decision in transfusing blood would be if during the surgery I am having uncontrolled blood loss. That would be one with unstable vital signs needing resuscitation.
Okay, good. Well,
like
definitely,
IV, like ephedrine, for example.
Right.
Cases in which I am reaching greater than probably 1,000 cc's of blood loss, where I would not anticipate something like that. A patient who has a hemoglobin that's less than ideal, so probably along the lines of 8 and already having ongoing blood loss. That's more than anticipated.
Okay, so hemoglobin less than 8 and blood loss that's more than anticipated. You said blood loss of 1,000 or more during a case? Good. And you said uncontrolled blood loss where the patient is becoming unstable.
Correct.
That's good. Anything else we should talk about that? I think that's a good list to start with. Anything else that you'd like to come up with that might be a criterion in just in a case like this, or any other major GYN case that you're doing?
Where I would transfuse in the case of it in the OR, you said?
Well, for instance, if you said a patient came in and let's say this patient started this case with a hemoglobin of 8. It sounds to me like perhaps the starting hemoglobin sort of influences the amount of blood loss at which you would transfuse. The hemoglobin of 8 in a patient like this, at what level of intraoperative blood loss might you actually decide to go ahead and transfuse? That perhaps you wouldn't if her starting hemoglobin.
starting, if I was still in the middle of the surgery, not concluded, and I've
Yeah.
already reached 1,000, for example, which is not
Okay.
common, but it can happen.
Right. Okay. Are there any instances in which, in a case like this, other than uncontrolled blood loss, you would elect to transfuse a patient if you had not yet reached a level of 1,000 cc's? It looks like here you had 800 cc's. It looks like you were beginning to think about it at least.
I don't think so. And part of it's a little bit of a clinical judgment at the time of the surgery. Because I obviously in the middle of a surgery, I don't exactly know what my end point of blood loss would be. But if I'm
Right.
thinking I still have half the surgery to go through with potential for more bleeding, then I would anticipate at least getting blood, not necessarily transfused, but at least have blood ready. So if in case I needed it, it would not be something that's out of left field for the
That's
OR.
exactly, as the examiner, that's exactly what I was thinking. You nailed that. What I wanted to ask you is, I wanted to hear how you planned ahead. So in a case in which you have, the examiner might say, so in cases like this, do you often encounter sort of difficulties and complications that prolong the surgical time or the operative time? In cases such as this, is it common that you might encounter a more difficulty in the procedure or technical difficulty or complications which would make the procedure substantially longer than you thought it might be?
It can be in certain cases where I have a large fibroid uterus, endometriosis, adhesive disease, complications.
Yeah, it could be. Would the length of the case in that instance increase the patient's potential for higher blood loss?
Yes.
Yes, good. In those situations, then how would you manage a patient in such a way that we didn't get into a situation of her blood count being lower than was safe during the procedure?
I'm sorry, could you say that again?
Sure. And you said what we led you to is there a situation there can be things which make the case significantly longer, and the longer the case, the higher the potential for blood loss. How would you manage a patient in a situation like this, thinking that the case may take twice as long as I thought? How would you manage a patient then in such a way as to minimize the risk that she could become acutely anemic and suffer complications during the procedure?
I see. So one would be to decide the best route. If I am indeed having trouble using, for example, in this case, I did have a robotic procedure. I encountered a complication and I decided the best route at this point would be to do an abdominal hysterectomy, not only to finish sooner, but also to do what I needed to do in order to make the surgery go more efficiently and in a quicker manner.
Good. Let's stop there. Jamie is really thinking sort of large picture, and that is an excellent answer. That's a very good example of what the examiners want to think about here. One way is we'd want to, if we realize the procedure is going to be unduly wrong, we'd start thinking immediately, is there anything that I could do here which could actually get the procedure to be shorter? Because the more difficult, the higher risk of complications. So that was a great example. Converting to a procedure in which you might be able to finish the procedure more rapidly would be great. That would lower the operative time. It would lower the likelihood of a higher blood loss and lower the risk of transfusion. It's sort of steps 1, 2, 3. Are there other things that you could do aside from that as managements that might allow you to sort of minimize the patient's likelihood of having a complication due to a very high blood loss?
Staying ahead of my lab level. So if, for example, I
There you
am
go.
encountering more blood at this time that's anticipated, and especially if I had a starting hemoglobin that was lower, then what I would like to get an intra-op hemoglobin hematocrit, platelets, and coag, just to make sure that I am staying ahead of the game.
Great. That was exact. I think that was exactly what I was waiting for. Les, would you move earlier to sort of assess the patient as a possible candidate for transfusion during the procedure? So, right, getting some labs. You mentioned sort of ordering up some blood and having it typed and crossed and ready, where you might not have actually been thinking of it at the outset of the procedure. Excellent. Is there any other way, and we're just sort of brainstorming, in which you could actually, in a situation like this, where you realize that the procedure was intensely more complicated than you usually would be, that we could lower the patient's risk of complications due to acute blood loss or higher than usual blood loss?
There is a higher risk of infection with higher blood loss, so normally redosing your antibiotics is appropriate.
Redosing your antibiotics would actually be good. That's great. Anything else in here?
From blood loss.
And I think it's right here on your case list, actually.
Are you saying intra-op or post-op?
Yeah, interop. Yeah, you realize the case is going to be significantly more complicated. You recognize the longer it goes on, the more likelihood of blood loss, more likelihood of low blood count, more likelihood of complications, and you'll probably have to transfuse her. So you're going to convert the case to make it shorter. That sounds good. You're going to check some labs and start thinking earlier on. You're going to look ahead to, should I be proactive in transfusing the patient rather than waiting until I get blood loss? That was actually very nice. Anything else that could help in a case like this?
Addressing my complication with a specialist that has the best
there
knowledge.
You go. Oh, that was reading my mind. That was exactly it. You had that urology intraoperative consultation, calling somebody else in who's got a lot more experience, and two really good pairs of hands like yours and your assistants, I bet, can get this done better, quicker and better, no matter what the route of approach. And changing the route of approach and getting like a general surgeon or GYN oncologist to would be sort of a double whammy for keeping that under control. Okay. Perfect. Jamie, that was great. That was you were right there, because that was sort of, I know it was hard for me to define that question for you, but that's exactly what the examiners want to be thinking in a case like that. I think you really showed a nice example of sort of how to back off and sort of think big picture through the exam and just sort of brainstorm as you go along, given where the examiner is trying to lead you. That was really, really nicely done. Thank you. That's great.
Thank you.
So let's give you a minute. Is there anything you'd like to add to what you've discussed, or sort of any questions about how we approach that?
In these types of scenarios where there's complications, will they ask me the detail of how it happened and recall?
Yes. Oh, of course. Yes. They'll ask you why you converted, what exactly was going on there. They'll ask you, they'll ask you, what sort of things could increase the risk of a bladder dome injury? And you're probably going to list a whole lot of stuff that was happening in this case with endometriosis and things like that. And they could say, so in this case, how did a bladder dome injury occur? They want to know exactly how and when you recognized it. And they're listening for you to say, did you recognize it at the time of, or did you pick it up later? And there's no right or wrong answer to that. The idea is always having a heightened awareness of the potential for complications to have occurred, looking for them to see if you can identify them as they occur. And also, as you go through the case, checking back to see if you might have missed a complication that occurred earlier.
Okay, thank you.
And that's great. No, that was an excellent question. That's exactly what they might be interested in talking with you about. Good, Jamie, that was actually nice. We've had 3 out of 3 really good ones again this evening. Thank you very much. Let's get Dr. Myers. Danielle, I'm going to get you unmuted for a minute, and we'll find your case list for just a moment. I apologize. I just have to scroll through them because they're not alphabetized yet. There it is. All right. Let's see, Doctor. Oh, good. Danielle, can you hear us okay?
Yes. Can you hear me?
Oh, good. Yes. No, we got you really good. Thanks. So your choice. Where would you like to go on your case list?
I'm okay with any of them. I'm guessing since we've already done OB and GYN, then maybe office.
Oh, okay. Let's see. I think we already did office actually, but I'll go back to office.
Oh, do we?
We have like, we're only halfway through the webinar. I'll do anything you want to. You get to choose. Do you have a preference for one or the other? I'll go back to the top here. You're taking the time, so you direct.
Maybe
office else.
I haven't practiced, I think. Well, maybe like OB.
Okay.
I don't know.
We'll go OB. That's fine. Let's see. Let's see here. Could we do case number 15, advanced maternal age? Because like the only thing in the case here is advanced maternal age, and she had a really nice delivery and outcome. She made it to full term. We take that for a moment. Are you aware of any present recommendations of considerations for a pregnant woman age 35 and older, as opposed to a woman who's 35 and under? In other words, are there particular ways in which we would sort of treat them differently during pregnancy, or things that we would particularly want to be sure to check out and provide as far as prenatal care in the 35 and older population?
So specific things I think of in the 35 and older population is discussing, genetic screening, as we know they're higher risk for aneuploidy.
Good.
I also talk to them about associated risks with advanced maternal age, which typically include higher increased risk for gestational diabetes, hypertensive disorders of pregnancy, stillbirth. Those are kind of the big things I touch on.
Okay, so you mentioned she's at increased risk of aneuploidies and chromosomal abnormalities. If she would ask you, but she's 35 years old, can you give me a ballpark figure for a 35-year-old as far as her overall risk of chromosomal abnormalities in this pregnancy?
It's typically about 1 in 300.
Okay, is that for particular types of chromosomal abnormalities or for all chromosomal abnormalities?
It's typically for trisomy 21.
That's good, for trisomy 20. How about for all, just for this pregnancy having any major chromosome abnormality of any kind?
It's about 1 in 180 or 200.
Okay. Which I think on last year's exam would be absolutely appropriate, but I brought this topic up because I saw it when it came to mind. Be sure everyone look at this, the August OB clinical care consensus, which is on pregnancy in women 35 and older. And on page 3 or page 4, there's a huge table in which they've redone all these statistics. And if you look at over the very right-hand column, it's the statistical risk of any chromosome anomaly. All comers, it doesn't matter whether it's a major aneuploidy or something partial. And they're quoting it as being in the 35 to 36 to 37 crowd as like 1 in 94 or something like that. But that's because if we went to their last time they did this practice, well, it was like 1 in 180, and Down syndrome was like 1 in 285 or something like that. But that is, I believe, because they've gotten so much more good with things like microarray testing and things like that, picking up other significant chromosome abnormalities that they didn't list before. So the important thing for the exam is if an examiner is going to ask you about statistical risk in this population, and they do, I think they do 25, 30, 35, 40. I would know sort of the basic risk of a major aneuploidy, and I would know that right-hand column because when they ask about that, we now need to talk about it in those ways, and the numbers have kind of changed. But moving ahead, so you mentioned that there are at increased risk of diabetes, term fetal demise, things like that. What would be your considerations in a woman over 35 as far as what you particularly want to provide for her for prenatal care that might not be so important in a woman who is 25 to 30? Can we make just sort of a short list of the ways in which her prenatal care would be different?
So typically, I mean, I would assess for risk factors for hypertensive disorders, and so it may be different just because of the fact that being over the age of 35, sometimes if they're like nulliparity, things like that may put them at increased risk. So I always talk about, baby aspirin if it's indicated.
Good. Would you give her baby aspirin based on her age being 35 or over?
If she's 35 and or over, not just that specifically, but she would have to have one of her moderate risk factors.
Good, that's good. Great. So baby aspirin, I'm all with you on that. What else? In what other way might your prenatal care be different than for a younger woman?
Gestational diabetes screening would be pretty similar.
Right. Yeah, I agree. Would you do early diabetes screening in a woman 35 and older?
Not without necessarily a risk factor, although BMI usually categories.
Right, the BMI and the personal and prior history of diabetes, family history would factor in, right? But not just beyond 35. Very good. What else in what other way might we sort of care for her differently during pregnancy?
The one other thing I forgot to mention is that they oftentimes have an increased risk of fetal growth restriction. So they typically offer, if they're between 35 and 40, I offer them a 3rd trimester growth ultrasound unless indicated sooner.
Very good. Very good. That is great. When in the 3rd trimester would you do that?
I typically would get them about 32 weeks.
Okay. Sounds good. We're actually doing nicely. Anything else that we should consider?
The other thing that they also...
Yeah, I'm sorry, you go ahead.
The other thing I also consider is weekly NSTs. Again, in the 35 to 40 range, I offer it to them, but it's I highly recommend it, almost make it mandatory after age 40.
40, yes. Is it a standard recommendation to your knowledge in the 35 to 40, 35 to 39 range?
The recent change is that it's not an actual recommendation, but
Good, great, good. So you'd mentioned the increased risk of aneuploidy. I noticed that you offer this patient genetic counseling. Would you offer this patient anything other than genetic counseling regarding the increased risk of aneuploidy?
if I've understood the question correctly, we routinely will offer them at least the genetic screening, and then
Sure.
oftentimes I do talk to them about a consultation with a maternal fetal medicine doctor, given that they can perform things that I can't perform in the office.
And what are you thinking of there?
So things that the patient may look for is like nuchal translucency. We don't have that ability to perform that in our office. We can do standard anatomy ultrasound, but if they are interested in a higher level, like a level 2 ultrasound, then I give them that option and refer them for those things.
Okay. But as far as concerning the increased risk of aneuploidy, are you aware of a standard recommendation aside from genetic counseling and things that we should be offering these patients as far as looking into that particular risk?
I'm not sure I'm understanding correctly.
Are you
talking about like a type
higher
of
risk of aneuploidies? So you're offering a genetic counseling. Is there anything else in your practice that you are aware that would standardly be offered to a woman of that age range as far as looking into the issue of her maybe having a higher risk of an aneuploidy in this pregnancy?
I mean, we pretty routinely recommend and discuss cell-free DNA testing.
Good, sounds great. Good. Anything else?
Pretty similarly to patients that are establishing prenatal care in general. I mean, we talk about cystic fibrosis carrier screening and SMA carrier screening.
Yes. Regarding major aneuploidy, though, so far you're going to give them genetic counseling. You're going to offer them cell-free fetal DNA or NIPS. Both sound good. Is there anything else that you would discuss or want them to know is available to them?
I think this is where you're going. If with that, I let them know that our genetic screening options are screening options, and I always give them that option for diagnostic testing if they so choose, which would be via, CVS or amniocentesis, and that also would require referral to a maternal fetal medicine.
Great, good. So you'd offer genetic counseling, you'd offer them screening for aneuploidy, which can be your first or second trimester screen, nuchal translucency, integrated screen, cell-free fetal DNA or NIPS, very common these days, and you'd offer them invasive diagnostic testing for that. Now, important question. Is that different than how you would counsel a patient who was maybe 28 years old, as far as the options for her regarding risk of aneuploidy?
I do talk to them about their risk, but theoretically, everybody should be offered diagnostic testing if they so choose.
Perfect. Good. Thank you. I apologize for harping on this, but I've been bringing this up in each of our courses because people sort of stutter on this, but just remember every single iteration of the practice bulletins and the committee opinions on screening for aneuploidy and offering our patients options. They keep saying the same thing. Every single patient, regardless of her age, should be offered genetic counseling, genetic screening, and invasive diagnostic testing for aneuploidy. And that is the 35 to 40-year-old. It's also the 15 to 16-year-old as well. Everybody, by the ethical principle of autonomy, gets offered everything. Perfect. Thank you. We'll let you go in just a minute, Danielle. Aside from increased risk of aneuploidy, is there an increased risk of structural anomalies in patients who are older when they become pregnant? For instance, increased risk in congenital cardiac anomalies, neural tube anomalies, major organ abnormalities, urologic system abnormalities.
I think typically with those, you have other risk factors or it's in coordination with a syndrome, although, we have some data support that you might find things with like microarray and those sorts of
but
things.
As far as moving away from the aneuploidy, but think about structural anomalies. For instance, chances that baby would have an ASD or VSD. Is that likely to be higher in a woman over the age of 35 as opposed to a woman who's 20 to 25?
I don't believe so, but I actually don't know.
It actually is, and particularly according to this
Okay.
obstetrical care consensus. And for that reason, when you read through this, and please do read through that obstetrical care consensus from August, because
I need to do it again, apparently.
it lists a number of things that we should do as far as taking care of our patients 35 and older, and then it lists the level of evidence. And the thing that caught my eye, and I'd like you all to see this, because this is going to be really important in the exam, pay attention to it, is every single thing that's recommended in this consensus is level 2C evidence, which is just the poorest, weakest level of evidence, with only 2 exceptions. One is, as Daniela, you mentioned, aspirin 81 milligrams in conjunction with any other risk factors. That's like level 1B. And level 1A is everybody gets offered genetic counseling, genetic screening, and invasive testing for aneuploidy. And everything else there, which is about 7 or 8 other things, is all level 2C evidence. But they said, Daniel, exactly what you said. There's an increased risk of growth disorders, and this could be fetal growth restriction or macrosomia. So a 3rd trimester ultrasound is specifically recommended, but it's level 2C evidence. Early dating ultrasound, because older women are at higher risk of complications during pregnancy, and having accurate gestational dating to know the appropriate window for delivery if they develop a complication depends on accurate dating. So an early 1st trimester ultrasound as well. 2nd trimester detailed anatomy ultrasound. It can be just a basic level 2, but because there is an increased risk in structural abnormalities in older women, they mention that very specifically in there. Therefore, be sure that you offer all of your patients an anatomy ultrasound. Now, when we step back and look at it, all of our patients, no matter what age, we really want to get early dating and early ultrasound, and everybody gets an anatomy ultrasound. And these days, it's not uncommon for many of us to be doing 36, 37, 38 week ultrasounds just to look for suspected macrosomia or growth disorders and things like that, all based on very low levels of evidence. But in the when you read this for the exam, I would really keep in mind the examiners are likely going to ask us what was in that OB care consensus, and also what were the important things. And everything is category 2C except for those 2 things: genetic counseling, screening, and aneuploidy, and baby aspirin. And everything else they would want you to know, but they would want you to know that it's based on very low level evidence, and it's something we should probably all be doing for all of our patients. Anyway, good. Daniela, thank you for going through that with it. I did want to touch on that just because that's something I'm quite certain is going to come up on the exam. We see it every single year that the ACOG publications that come out within 4 to 8 weeks of the exams are automatically structured case questions, just almost across the board. So Daniela, let's give you a moment too. Is there anything you'd like to talk about this further? Just kind of questions or any other thing on this that you'd like us to discuss?
That I can think of. Is it well, I guess my only question would be, because I know they said in the obstetrical care consensus, like they kind of more emphasize that a lot of this stuff is more indicated over 40, like the induction around 39 weeks. And
yeah, that's true.
Is there reasonable?
That's true. There are a few things that they do say specifically for over 40, like maybe you consider the antenatal screening or the NSTs. Yes, I'm sorry, go ahead.
No, it's okay. So being over 35, is it reasonable to say that I give them that option versus saying
yes,
like I
I think I would say I give them the option, but I recognize that it's not a standard recommendation, although really it's becoming one over age 40. I would qualify it.
And I can say that, and that's fine.
They would certainly accept that. They would not ding you for that.
Okay, perfect. That's all.
Yeah, thank you very much. Thanks. Let's get right back out and oops, back in September. There we go. Let's see. We'll run down and check on our candidates here for just a moment. Dr. Snook, Lindsay, may I come to you, and let's see if we can get Dr. McCune and Dr. Four at least before we finish here. So Dr. Snook is sitting right in front of us. There we are. All right, Lindsay, I'm ready. What would you like to talk about this evening?
Let's see. I guess we can do. I think we're on GYN or office, so I think one of those would be good.
Let's see. Oh, I'm sorry. Sure, maybe we'll go GYN. Okay. So while we're looking at this, is there anything you've been recently looking at that you'd like us to take a stab at this evening?
No, nothing specific.
Okay. Let's see. I'm going to try and find something that we haven't actually talked about much recently. Can we do maybe case number 56, just inpatient surgical management, PID and TOA?
Okay.
Manage this pretty quickly. So 26-year-old, you got acute on chronic. I'm assuming that's chronic pelvic pain with the acute exacerbation. Admission diagnosis of pelvic inflammatory disease. She does have pelvic congestion syndrome, no masses or anything else. You got gonorrhea, chlamydia, community. So this looks like she was just sort of treated as an inpatient for PID?
Correct, yes.
Good, okay. I think the examiner first would say, I mean, don't you treat most of your patients as for PID as an outpatient? What particular criteria would lead you to admit a patient to the hospital to treat them for PID?
So criteria for inpatient management of PID, I would consider, so if the patient was pregnant, which in this case, that was not the case for here, but that would be a criteria.
Oh, no, that's fair. I think the first one we should mention is pregnancy. Very good, go ahead.
As well as nausea or vomiting to where she cannot tolerate like an oral antibiotic regimen.
Ah, okay, good. Is there any other reason why nausea and vomiting might be an important criterion for inpatient rather than outpatient management? You're absolutely right. I mean, she does have to be able to tolerate an oral antibiotic. Is there any other significance to nausea and vomiting that might be related to another criterion for inpatient management?
Well, if it was, I guess if her nausea or vomiting was related to the level of pain she was having, so that was something else I was thinking, you know, like severe pain for pain management, and the need for, potentially the need for like IV antiemetics, pain medicine for symptom management.
Yeah. Does nausea and vomiting have any other significance, though, as far as a possible sign of acuity of a process?
Well, I mean, I would want to make sure it wasn't related to something that was not PID.
Yes. What else might you think of there? Good. Good.
Yeah, so I mean, I just would want to consider other etiologies in my differential diagnosis for pelvic or for acute pelvic pain. So the number one thing that like being appendicitis, possibly, or like a potentially like a acute diverticulitis or gastroenteritis, and that was something that was a concern with this patient, and that's when she presented to the ER. So that's why she had the CT scan done initially.
Sure. No, good. Yeah. Good. Good. The major category I think we're trying to get here is that nausea and vomiting might be a sign of an acute intraperitoneal process, which is just a broad category of they get treated as symptoms, because you're right, it could be appendicitis, it could be something GI, diverticulitis can be an acute procedure. We have talked about TOA, but TOA is sitting right up there. Good. That's good. So I think nausea and vomiting for those two reasons. What else can we come up with other indications for treating her as an inpatient rather than an outpatient?
So another inpatient criteria would be if she had a TOA.
Yes, very good. Yeah, what else?
And then another possible criteria, I don't think it's like a strict criteria, so to speak, but if you're concerned about the patient's ability to follow up, or
yes, that's not an iffy thing. That is a very important criteria. In fact, that's on the list. The CDC has a list of recommendations for inpatient, and one is concern for ability to comply with outpatient management, because that inability to comply puts the patient at risk of serious complications, untreated PID, stuff like that. No, that's a very important one. Very good. Good. One more I think that's related to this issue is she might have an appendicitis or diverticulosis or something else like that. When this patient came into the hospital, you've listed over here on the left-hand side PID. Was that your firm confirmed diagnosis at the time of admission, or was there some question about that?
So there was some question about it.
There's some question. Yes.
Yeah. So the main concern was for appendicitis due to her level of pain. So
good. And the other thing on the CDC list is when the diagnosis is in question. So it talks
Okay.
about sort of PID being at the top of the list, or we're not certain the PID is the top of the list. Maybe appendicitis is a little above PID. Anything where the diagnosis is uncertain and further evaluation is needed is a really important indication for admission. Good. I think that's the list. We got I think 5 or 6 things out of there, and that is exactly the list that the examiners want to hear. Good. So in this case, if this patient had if the ultrasound had actually showed something that appeared to be a tubo-ovarian abscess, how, if at all, would your initial treatment of this patient have been different than what you're doing in treating her for PID?
So if this ultrasound had showed a TOA, it would not have changed my management initially. So regardless, she was getting admitted for IV antibiotics, which we can use for initial treatment for TOA.
Okay, say that once again. I think you're good there.
I was saying that I would, regardless, I would admit the patient for IV antibiotics in the setting of the TOA.
Would you be using any different IV antibiotics if this were a suspected TOA rather than just straightforward PID?
So I would not. I use the same 3 antibiotics for management.
Good. No, that sounds fine. I think we'd be using the same thing. Would your initial management be different in any other way? So you'd bring her in, you start her on exactly the same antibiotics. Would your initial management involve anything different if she had a apparent TOA?
I mean, I think that would potentially depend on the size of it.
Okay. Good.
Yeah, because
I agree. Yeah, how can you tell me? Tell me about in your hands, in your practice, what size are we talking about? Why does size matter here?
So, well, so the size would help you determine the potential response it would have to the IV antibiotics.
Great, there you go. Yes, so the question here is, if you put her on your standard antibiotics for PID and she doesn't improve, what would you do?
Okay, so,
she has no TOA. If she was garden variety PID, put her on standard antibiotics in 48 hours, she's not better, what would you do?
So at that point, I would want to discuss drainage of the TOA.
Oh, I'm sorry. What I was asking is, she was just standard PID, did not have a TOA. You put her on antibiotics in 48 hours, 24 to 48. She wasn't really getting better. What would you do there?
Oh, for standard PID. Okay.
Yeah. In that instance, what would you do if you just didn't show initial improvement?
So I think initially, and this is still inpatient. You were IV antibiotics. Okay. I mean, I think initially I would re-image her.
Okay, sure. Sounds good.
To see if there's any change there, and then
I like where you're about to go. Go ahead.
Brought in the IV antibiotic regimen.
Yeah, we might actually change our antibiotic regimen. I agree, and we might consult ID, or we might, look it up and do it ourselves. But if she had a TOA, if you had a TOA here and she didn't improve in the first 24 to 48 hours, what would you likely be doing?
Okay, so in the setting of a TOA that is not responding to IV antibiotics, I would discuss drainage of the abscess.
Perfect. That sounds great. Yes. Good. No, that was exactly where we want to go. And again, we just sort of made this up as we go along. I think the examiners could have taken any one of these texts. They could ask you about the type of antibiotics used for PID, and then, if you had a TOA, would that be different? I think it's reasonable that they would ask in cases like this, because this is a fairly simple case. She came in, she got some antibiotics. I think she probably went home. It was a non-surgical admission. They would just be hard for them to resist asking, so what if she didn't get better about that? I think that's about sort of the differential diagnosis as far as outpatient versus inpatient criteria is kind of obvious in this case. And they could actually, and since you very specifically said there's no ovarian masses, no free fluid, no concern for torsion, they would simply say, well, suppose there was a torsion, or suppose there was a mass, or suppose there was free fluid, how would you manage it differently? So I think those are all the different ways they could come at that case. And we hit maybe 2/3 of them, but you did a really nice job on all of that, Lindsay. Thank you very much. Would you like to bring up any questions or anything otherwise that we should chat about on that?
I don't think so.
Good. No, thank you for doing that. That was great. Really, I have to say, very well done. Thank you. We're going to go to Dr. McCoon and then I think catch Dr. Four for a moment. Caitlin, I've got you unmuted. I have to go find your case list here for just a minute with me. While I'm doing that, can you hear us? Okay, it sounded like we could hear you there. There we go.
I can hear you. Can you hear me?
Yes, we're good. Yes, thank you. All right, I've got your case list up. Where would you like to go?
I am really okay with anything. There's one case in GYN that I'm particularly worried about, but it's in GYN and we just did that, so I'm okay with
No, you're the one who is stepping up and being brave here. You get to do whatever you want. This is your time, so I'll go GYN. That's fine.
So it's case
You're
one.
running this. It's case what?
Yeah.
Oh, so you said case one?
Yes, sir.
Oh, good. Okay, right in front of us. All right, good. So tell us about this case. You can give us sort of a 30-second nugget summary of what concerns you in this case.
So this case is a patient who presented postpartum day 9 with endometritis, and over the course of her evaluation, we became concerned for group A strep. I'm particularly concerned about it because it's an unusual diagnosis.
Yeah.
He ended up not having it, thank goodness. And management, obviously is severe. So I just want to make sure I know that I can defend the choice
Sure.
we made.
Yes. So sure, this is post-49, post-cesarean delivery. I'm assuming this patient returned to the hospital or to the office with some concerning signs. Is that how this began to develop?
He initially presented to the office complaining of foul smelling, lochia, a headache, and some like nausea. When she presented to the office, she was noted to be febrile to 102, and did have pretty foul smelling lochia, as well as some mild fundal tenderness, but not what I would expect for her, the remainder of her clinical presentation.
Good. So maybe differential diagnosis of fever and foul smelling lochia on day number 9 after a C-section. It's not going to be a hugely long one, I think.
Correct. So my first thought was postpartum endometritis versus a surgical site infection.
Oh, good. What sort of surgical site infection could cause foul smelling lochia?
So in this particular patient, she had a C-section. So I think that
Yes.
if she had a deeper or an infection that kind of spanned all of her layers, she could have some foul smelling lochia. This patient actually ended up having a C-section because she had a failed vacuum. So if she had some sort of tear in her vagina, which she actually did, she could have also had a site infection at the site of her tear.
Good. I think that's thinking very, very nicely. So we always think postpartum endometritis, when she's had a cesarean delivery, automatically brings up, was there something sort of as a complication of the procedure that maybe wasn't managed properly or has broken down? So surgical site infection could actually involve a failure of the uterine incision. It could be an unrecognized sort of extension or paracervical laceration that's not repaired. We might actually now have a communication within the peritoneal cavity, or there's some infection. In rare cases, it could be abdominal wall stuff. It could be a vaginal laceration as well. Good. So what, if this patient had postpartum endometritis, what types of bacterial flora would you normally expect to be involved?
I would expect it normally to be a kind of a multifloral infection, just with kind of the typical vaginal flora.
Which would include what, just a few examples maybe.
So possibly, I guess E. coli could be part of it.
Yes, I like that. Good.
I think E. coli is the biggest one that I would expect.
Okay, sure. Good. So do you have a particular concern for potential for group A strep? What are the implications of that for you?
So in this particular patient, we were concerned about group A strep for several reasons. One, her physical exam, she really didn't have very much tenderness, which seems to be pretty typical of group A strep because of necrosis. She was febrile, she was tachycardic. She also, we actually did an endometrial biopsy on this patient, which came back gram-positive cocci, which gave us concern.
So what are the implications of group A strep? Are there particular implications of having a group A strep endometritis that concern you in particular?
So from my knowledge of this case, the mortality and morbidity and mortality of group A strep is extremely high if the patient becomes septic, approaching like 60%. Was our primary concern given the fact that I have a very small facility that would not be able to manage an ICU level patient.
So how would you then manage this patient? If you had a presumptive diagnosis now of group A strep in this situation, what would be your preferred way of managing it?
So my preferred way of managing and what we attempted to do with this patient was actually to transfer her to a higher level of care.
Right. I think that given what you just told me, that's exactly what the examiners would want to hear. That sounds very good. Go ahead, though.
We attempted to, unfortunately, I was in a very small facility abroad in Japan. And when we attempted to transfer her to a higher level of care, no hospital would take her because there's no such thing as EMTALA in Japan.
Oh, I guess I see.
Wow. So in this particular case, transferring to a higher level of care was not an option. Yeah. Which is, the biggest reason I'm concerned about this case is I think that given that she didn't actually have group A strep, she may have, her final pathology did show like ischemia and necrosis into the endometrium.
Right. And she had cocci,
Yeah, so I just am concerned that there will be question of, if I took her uterus out too early and should have given antibiotics.
Well, let's give you a minute to defend that then briefly. So what would your defense be as to why in this particular situation and not having the benefit of hindsight at all, you determined that you needed to move aggressively toward a hysterectomy?
In this particular case, the resources that my hospital had played a huge part in it. This patient was not sick when she presented, but definitely had signs of concern for developing sepsis. And the decision that we made with shared decision making was to attempt to control the infection early and aggressively rather than risking her getting more sick, becoming truly septic, and having that 60% mortality rate.
But how would performing an emergency total abdominal hysterectomy assist you in managing her infection better?
So if the source of the infection is her uterus, by taking it out, you're controlling the source.
There you go. I think that's all the examiners would need to hear. You're solid on that. I think they will sort of push you to confront you and things like, well, is there anything else you could have done short of removing her uterus? Well, how about you just give her antibiotics for another 24 hours and see how she does? If they put that to you, how would you respond to that?
So I think in that situation, I would talk about the counseling that I did with the patient and the shared decision making of, certainly we can try to save your uterus by doing antibiotics for 24 to 48 hours. However, if this is what's going on and you become sicker, there may come a point when we cannot care for you and don't have the resources.
There you go. That was exactly right. You were recording 60% mortality if she actually has group A strep. You're in a small facility where she becomes that sick, you can't stabilize her for transport. And she would likely die in your facility. You can say it exactly like that to the examiners, because I have a feeling there's some truth to that, isn't there?
Yes.
Yes.
I think I made the right decision at the time.
I agree. Every examiner who's sitting across the table, I think, is going to be certain that you made the right decision, because you've described it very nicely. But they're allowed to push back and just sort of see if you'll stick to your guns. Absolutely stick to your guns. Okay. And you should say, this is a small facility. I could not transfer her. I was very concerned of her developing sepsis. I can't manage that. Once she becomes septic, performing surgery in that situation carries a very high mortality rate. We wanted to be proactive and stay ahead of this and give her the greatest chance of survival, given that in this situation, and given what we knew at that time, there was a significant likelihood that she might not survive.
Okay.
That sound okay? Because I think that's what you told me. I think I'm just paraphrasing it back to you.
It's such an unusual case, and it was actually the
It
first
is.
in my case collection. I
Yeah.
just
Oh, and I'm certain they're going to ask you about it. So definitely practice a couple more times with other people so you can get comfortable with it. But you've got a really good case there, which you managed very, very well, and undoubtedly saved your patient's life.
Thank you.
I think there's no question about that. Good job, Caitlin. Thank you. Let's go to Dr. 4 for just a moment. Now we're coming up on the end here. I do want to save a little bit of time for questions. Matthew, I'm trying to get you unmuted here for just a moment. We kind of had to finish early last time, so if you all don't mind, we might run over just a few minutes tonight just to be sure we can give everybody. Matthew, I think you're up here. Can you hear us okay?
Yes, I can hear you.
Oh, good. Thank you. I'm sorry. I've got one eye on your mic over there and the other eye as I'm trying to find your case down here. Ah, there it is. Dr. Oh, good. All right, I'm ready to go. What would you like to talk about this evening?
Whatever works for you. I have no preferences.
Okay, let's see. Let's see. At some point, we're going to get to office, and we didn't. Can we do office for this will be our last case of the evening?
Sure.
Okay. Now, but since this is your case list, any particular case or topic that you've been studying or looking at that you think you might like to touch on this evening?
I guess one of the later cases. I haven't really had anything specifically, but I've been asked a few things on this earlier.
Yeah, we're done. Let's see. Good. Let's see. Let's see. We're landing on breast stuff. Can we do breast for a few minutes? I bet we haven't done that in the past several days.
Sure.
Okay. All right. Let's see. Let's do 24 because we've already talked about infections a lot this evening. So 49-year-old cystic breast mass, history of benign breast cyst, history and declined. She declined a clinical breast exam. Okay. She ordered a diagnostic mammography with ultrasound. What could you define for us? What is diagnostic mammography?
It's using the mammographic technique of localizing the area of concern with multiple views.
Oh, good. Okay. Does diagnostic imaging generally include ultrasound as well?
Not typically, but given her history of benign breast cysts and what was palpated, or what she described as a similar, well, she described it as a recurrence of a cystic breast mass. I also felt like an ultrasound was warranted.
Okay. Now, Matthew, I would check in your community to see what your community radiologists, how they work this out. But that's the general way that we approach this, according to the American Academy of Radiology and the Biomass classification, is we have screening mammography, which is what she gets every single year. And then we have diagnostic imaging. It's not called diagnostic mammography, it's called diagnostic imaging. And that would be, as you're right, sort of a cone down or magnification or several view mammogram of the area in question. And then the option to do a contact ultrasound, because you're imaging the tissue in two different ways. And usually diagnostic imaging is considered to include both of those at the radiologist's discretion. So I might answer it that way. But I think you're exactly right. So in this case, you found a 3.3 centimeter oval mass consistent with a benign cyst. When you get the report back and you're just talking about it with the patient, what information on this report might lead you to recommend perhaps a aspiration of the cyst rather than just expected management? In other words, you chose expected management here. What about this case would have to be different for you to recommend that she actually have the cyst drained?
Typically, if she were having any other symptoms related to if she had overlying skin changes or abnormal nipple discharge or neuropathy.
And what would concern you about those? What would you be worried about if you saw those sorts of changes?
Those sorts of changes would increase my suspicion for possible malignancy.
Good, great. So conditions or other findings suspicious for malignancy. What else might lead you to recommend an aspiration rather than expected management?
If she was having symptoms, if this was
very good. Symptoms
growing in size.
Increasing in size, good. So watching it over time and it increased, good. What else?
If it were not simple appearance on if there was any sort of vascularity or complexity to this fluid.
Good. So for all the rest of us who are listening along here, as Matthew is doing this, what I'd like us to notice is we're actually running down the differential diagnosis when we talk on this case list about adnexal masses and how do we decide when to observe it and how do we decide whether to operate on it. The list is basically the same. If it is something that is complex rather than simple, if there's signs suspicious for malignancy, if it seems to be increasing or changing its character over time, if it is symptomatic. In some way, it's all the same thing as if we're talking about an ovarian cyst, and you can just walk exactly down the same line. And Matthew, you're doing a great job with that. And so you mentioned vascularity, you mentioned skin nipple changes, signs consistent for malignancy. If you elected to, you and the patient elected to have the radiologist aspirate the cyst, what studies would you want the cyst fluid to be sent for?
So I'd want it sent for cytology, and then if they have a cyst wall, that would be for histology.
Great, okay. Perfect. If all they sent for was cytology and the cytology came back identifying atypia, how would you discuss that with the patient and what would that mean to you?
With atypia, on cytology only, sorry, you said?
Yeah, all they sent was cytology. You know, they didn't get a cyst wall, they just stuck a needle in and drained it.
Okay. There's a possibility that it was a poor collection in that it gathered other cells on the way on aspiration, but there's also a possibility that it could be an abnormal cell changes within the cyst wall, which could be concerning for possible malignancy or pre-malignancy. Therefore, I would recommend that she discuss with breast surgeon to discuss possible excision or other options for her.
Great, good. Where do you think they go? Where, if it were just atypia, we had a concern that the cyst itself was pre-malignant, or you said actually in passing through, we might have gone through an area where there are atypical cells. What diagnostic test might the breast surgeon first perform?
I guess they could do a ductogram or MRI.
Okay. And what additional information would that give us? So we already have cytology that shows atypia. Usually, if we've got atypia, what's the next thing that we do?
Excision.
But exactly. So this is exactly this, and again, the same thing as we talk about Pap smears or VIN or something like that. If we have a potential, we're trying to determine if a lesion is pre-malignant or malignant, we do a diagnostic excisional procedure like a leap or a cone or a wide local excision of the vulva. Same thing here. We've got atypia, which may be pre-malignancy or malignancy. If we're evaluating for possible malignancy, we would do a wide local excision. Basically, you would take out the cyst and the area around it. It wouldn't necessarily be a lumpectomy just yet because you only sample that local area. That's where your atypia came from. But it would be basically a wide local excision of the breast tissue surrounding that cyst. Exactly. Okay. And last question, if then the result on that showed a focus of contained ductal carcinoma of the breast, what would you expect the patient to undergo next?
Typically, if it was like in situ or?
No, it was actually invasive ductal carcinoma, maybe 5 millimeter focus.
Okay. She would likely require mastectomy with possible. She could be, well, sorry, for ductal carcinoma, she could be a candidate for lumpectomy.
Lumpectomy, good. Lumpectomy. What else might be performed at the time of the lumpectomy? Are there other adjunct studies that are usually done during lumpectomy?
With sentinel lymph node biopsy, probably.
Sentinel node lymph biopsy. And if the sentinel lymph node were positive, would they do anything else?
They would probably do, I don't know if they would do a mastectomy versus radiation.
No, but if the sentinel node is positive, the sentinel node is the first node for primary drainage out of the area where the lesion is, right? So if that's positive, what would they do next?
I guess chemotherapy.
Well, during the surgical procedure. You do the sentinel node and you send it off for frozen section, and actually they give you a read on it during the procedure because you would want to do more operation, and it's not a mastectomy. So if our first lymph node out in the chain is positive, what would they do next?
Then I guess they would do a full staging procedure.
Well, they do selective lymph node sampling. They would condense because now we're looking for where the nodes are now determine the staging of the procedure. So you're actually right. It is staging by now evaluating are there any further lymph nodes that are positive. And then that leads into staging. Perfectly good. Matthew, thank you for doing that. That was actually nicely done. So let's give you a moment. Is there anything about this case that we sort of made it into something obviously that it was not, but that's what office practice is all about. Anything about sort of the topic we talked about that you'd like to ask questions about, or is there anything you'd like us to spend a couple minutes discussing further?
I don't think so. No, thank you.
Oh, great. No, Matthew, thank you very much. While we are scrolling back up here, we're going to close in a couple of minutes. I'm just scrolling. I'm going to let Matt sit down for a couple minutes. If we will take questions for a couple minutes. If anyone has questions, we got a couple people who have their question marks raised here. I'm going to hit. Let's see, Dr. Schneider. Jessica, I'm going to unmute you for just a minute because you had your question mark there. If you want to unmute yourself, if there's a question that you would like to ask. Yeah, Jessica, go ahead.
Sure. It's unrelated to anything we did today, but I was looking to have a recommendation for a resource that has a comprehensive list of age-appropriate screening recommendations for a well woman exam.
Oh, goodness.
It's coming up really short.
Oh, well, let's see. The ACOG has done something on the well woman exam. It's a few years old. Let me think what else we can do. United States Preventative Health Services Task Force, the USPTS or whatever that is. They've got, if you go on their website, United States Preventative Health Services Task Force, they would have all the references on that, on sort of the general recommendations for men and women, and do 40, 45, 50, 55, 60 and out of there. At each particular step, what would be recommended. And I believe they include things like immunizations also.
Thank you so much.
But the well woman, look at that for the well woman exam. And then if you need to, also just the basic schedule of adult immunizations, which is on the ACOG website, because that is sometimes separate, but they would ask you about that.
Thank you.
Good, thank you. Let's get to Dr. Tushkarian from Serene. Going to get you unmuted because I think you had a question. Go ahead, Serene.
Yeah, hi, I typed it out, but a question from something that we talked about on Sunday night. It was a case regarding AIS on a patient who was done child visit.
Yes. Yeah, I remember that, yes.
So just my question on that was, I thought I understood that it was said that if they're done childbearing, hysterectomy should be performed, and I agree with that, but I thought that a cold knife cone or an excisional procedure would need to be done first before jumping to a hysterectomy. Is that not true?
No, that is actually true. You would want to, if we were managing it, we would want to rule out invasion before we perform a hysterectomy. And that's true for squamous lesions, and it's true for, you're right, absolutely, for in situ adeno lesions as well. But this might have been in the situation where we had already referred on to the GYN oncologist, and recognizing, just like with the EIN, the high likelihood of a coexisting present carcinoma, they might actually move directly to a hysterectomy with a frozen section and a staging procedure as well.
Okay.
But you're right. If they were asking you if you were the primary person managing this, what would you do? And I would quote to them sort of the statistics about the likelihood that she already has carcinoma. But I'd say in order to proceed further, we actually should do a formal diagnostic excisional procedure, which is a conization and a DPCC. And then I would refer to GYN oncology from there. That would be perfectly correct as well.
Okay, thank you so much.
Great, thank you. And let's see. Questions up here. Thank you. I'm going to take, let's see. Oh, Dr. Castillo, I think also had a question. Jamie, did you have a question for a moment?
No, sorry. I was just letting the person know that under USPSTF, there is a chart with different ages and what types of vaccinations and lab work would be recommended and how well those recommendations are. I did see that.
Good. Yes, I think that's what I was referring to. That'll definitely get you started. Thank you, Jamie. Thank you very much. Let's see. Dr. Walker, Alyssa, I think you are. Alyssa, do you have a question? Go ahead.
Yes, sir. Just quickly, I just didn't understand the answer to, I guess, the question that you were asking the gentleman about the positive sentinel node. I didn't get the answer.
Yeah, so if the sentinel node is positive, they would then proceed on to sample axillary. It would usually be axillary lymph nodes, but if it's in the medial part of the breast, it'd actually be intramammary lymph nodes. The staging depends on which lymph node groups are positive. So if the sentinel node biopsy is negative, they identify that by ejecting dye right where the cancer lesion is, and then seeing which lymph channel it goes to, and they biopsy the first lymph node out there, and they actually can radio tag this as well. And if that is negative, then they consider there's no need to do further lymphadenectomy. But if that is positive, then they have to go further and get axillary or internal mammary lymph nodes, or whichever ones are going to be the closest to the lesion.
Excellent.
And that's just some of their staging.
Okay, thank you.
Good, thank you. And let's see, one person with a hand raised here, I think just disappeared. Let me just go look for a minute before we close. Dr. Walker, Schneider. Oh, Dr. Burton, I'm sorry, Dr. Burton, I was looking for you. You're way down at the bottom. Let me unmute you for a minute because you had your question mark raised. Also, if Dr. Burton, if you have a question, just unmute yourself for just a moment. And if not, that's okay. Oh, there you go. Hi, go ahead.
No, it wasn't a question. I think the case she's referring to was an onc fellow, if I remember correctly. And the fellow was just saying like, that's why she had taken it to that step.
I think that's right. I think we had already moved it up the ladder to gynecology. That's correct. Thank you very much. Thank you. We do need to stop for the evening. They cut us off at about 15 after the hour. So thank you again, all of you, for joining us this evening. We've had, again, some excellent discussions. Tomorrow will be, of course, case list, structured cases, Monday and Wednesday. And remember, this month we have added in Thursday evenings as well. And those would be extended sessions where we do case list review just like we did tonight. I will be back with you, I think, in about a week, and I will look forward very much to that. Thank you all very much again. Remember, these are archived as podcasts. You can go back and listen to them again at your leisure between now and actually the exam. Whenever you take the exam, they are readily available to you. Thanks, everybody, for attending, and have a very pleasant rest of the evening.